Okay, well, good morning. As you kind of noticed, my talk is very similarly, for those of you who are eaglet-eyed this morning, my title is actually very similar to Pat's. So Pat's kind of stolen my thunder this morning, but I'm going to just tackle this topic from a slightly different kind of point of view. So what is it that we actually consider when we consider the ocular topography? Well, the standard model that we have in our minds is this either a spherical model on the top left or an ellipsoid model. In reality, the cornea is far, far more complicated than that. And if we look at an ASOCT scan on the bottom there, we can see that actually it's a much more complicated structure. Not only is it semi-spherical in the center, but we have this kind of tangential form and shape on the edge, and we also have that kink on the nasal side. So we have a kinky cornea. In reality, the cornea and the ocular topography shape is far, far more complex. You can see from the graph on the right that it is effectively an elliptical center, an ellipsoid shape. But as we go to the periphery of the cornea, it's actually a conocoid ellipsoid. And then as we go into the peripheral cone and the scleral cone, it then starts to take on a tangential shape. So our traditional understanding of the corneal topography is actually rather limited. What we want to be thinking more about in terms of contact lens practice, certainly in terms of specialist contact lens practice, and certainly in terms of scleral contact lens fitting, is to consider the whole ocular profile. So what we want to do is move away from this corneal model in our minds to a completely ocular profile. So let's just step back a little bit and think about what tools we have in practice that actually enable us to measure. With keratometry, we're limited to that central 2 to 3 millimeters corneal cap. But as we've seen from the previous ASOCT slide, actually that's a gross misrepresentation. It doesn't take into account any of the change in peripheral corneal shape and the eccentricity of the shape. Just out of interest, how many of you are still using keratometers in day-to-day practice? Okay, one. Okay, how many of you are using corneal topographers? Great. Any of you have got ASOCT at all? This is, I think I'll go along with Brian, this is an advanced crowd. It's very interesting that the penetration of corneal topographers is actually relatively low in the UK. It's about 4 or 5%, where actually a fair number of you put it up, so you're advanced practitioners for sure. Keratometry is useful. It can give us some ideas of steep fit and tight fit. It also gives us a sense of tear breakup time, and so it gives us some kind of qualitative measures, but it doesn't really give us many quantitative measures outside of that central 2 to 3 millimeter cap. So let's just look at the type of technologies that we're currently using. We have Placido-Disc corneal topographers, which is what the vast majority of corneal topographers are in practice. There are also LED reflection type corneal topographers, which I'll come to in a second. And of course, there's profilometry, and the only system doing that currently is the Eaglet Eye ASP. So the current kind of models on the market, Placido-Disc, as I say, instruments like the Medmont, LED reflection systems like the iOptics, and of course profilometry with the Eaglet Eye ESP. But what I really wanted to make, the important point about these things is, you noticed Brian talking about a lot of ographies earlier, but Placido disc-based systems and LED reflection-based systems are exactly that. They're reflection-based systems that reflect and rely on specular reflection of the tear film. So they are limited to just the corneal topography. Now, as I said earlier, when we're thinking about contact lens fitting and more advanced contact lens fitting, we actually want to be thinking outside of the cornea. When we look at profilometry with the ESP, we're actually talking about ocular topography. So we're talking about being able to measure the whole of the cornea to the limbus, and as Brian said, up to 20 millimeters outside outside and into the sclera. So with Placido disc-based systems, the mires are projected onto the eye. The rings are then captured via CCTV and then digitized, and the slope between them give us some sense of the curvature of the cornea. And of course, when we then get very distorted corneas with keratoconus, as the rings get further and further apart, they give us a sense of just how distorted that cornea really is. But there are a number of inherent limitations with Placido-Disc-based systems. The primary problem is that there are a finite number of points that you can actually digitize, and when you get a very, very distorted image like that on the right, it's actually very difficult for the instrument to tell those distortions apart. So what you tend to find is that Placido-Disc-based systems, particularly for irregular corneas and keratoconic corneas, actually start to become significantly inaccurate. Some of those problems can be overcome with the use of small cone corneal topographers, but nonetheless we're still limited to imaging just the cornea. The LED-based systems try to overcome that. I don't know, have any of you seen this device? Yeah, it's a really interesting device, and it looks something like it looks a bit like one of those 1970s disco mirrors. The clever thing about this technology is that the LEDs, when they're projected on the cornea, the instrument knows the location of the different coloured LEDs. So what it can do is it can actually work out and separate those distortions so that it overcomes some of the basic limitations of Placido-Disc-based systems, and in so doing is a little bit better with more irregular corneas. However, you are still limited to the fact that it's a specular reflection device and therefore can only image up to the limbus. So that brings us to the ESP. You may have heard mention from Brian earlier that the instrument uses fluorescein, and this allows us to image not only the cornea, but because you have fluorescein over the surface of the sclera, you can image from there. And the great advantage of this is that you can then gain direct measurement of height from the whole of the cornea and out into the sclera. Now, when I say direct measurement, that means there's no extrapolation or interpretation of the data. With Placido-Disc-based devices, they work on slope, the separation between the rings, and then the height is then calculated, and they make a lot of assumptions. And as the eye becomes more irregular, those assumptions become greater and greater and greater, so you do not get accurate representation of height. With this type of technology, the measurements are taken from height first and then converted to curvature, so you get a much more accurate interpretation of height. Of course, we also have anterior segment OCT, a very useful tool, but certainly for many people, very expensive just to have a purely anterior segment OCT. Has anybody got a dedicated ASOCT machine? Yeah, and you're very lucky. Generally, the cost is so high that they're really limited to research establishments and universities. But the Zeiss Visanti, which is one of the very few instruments capable of taking the whole width of the cornea, has actually just been discontinued. You're looking at about £50,000 to buy one if you do. But the great disadvantage of these, of course, is that you can only take one scan in one meridian at one time. Whereas with an instrument like the ESP, it actually images the eye 360 degrees around the eye simultaneously. So a great research tool, but the ASOCT, but actually very time-consuming and not terribly practical in practice. So just a quick review of those technologies. Keratometry, we're looking at a central 2 to 3 millimeters. Video keratoscopy with a standard Placido-Disc-based device or an LED reflection-based device, we're looking at something like 8 to 10 millimeters coverage. Projection-based systems like Pentacam and shine flood type imaging, which I didn't mention, you can get up to about 12 millimeters. But beyond that, the reflectance of the sclera actually limits any useful measurement of the sclera whatsoever. We have anterior segment OCT, which I've just said, which gives us up to about 15, 16 millimeters, but costly. But with profilometry, the ESP, we're able, as we said, to measure up to 20 millimeters. Now, we talk about 20 millimeters width, but Brian made the very good point earlier that you can actually separate the eyelids and actually image wider vertically as well. And just a tip there, if you do that, have a go at that, just to always just gently hold the lids, try not to deform the sclera, and you'll get some very, very good and accurate readings. So what about the peripheral ocular topography? That's the thing we're really interested in. Well, we do have instruments like the Medmont, and this gives us some compasing, which allows us to go a little bit further out towards the limbus, but that's not enough. We have the ASOCT, as we said, but the ESP certainly gives us the widest coverage of all those instruments. So what about the anatomy of the limbus? As I said, our standard corneal model makes the assumption that we have an abrupt transition from the cornea into the sclera. This was a piece of work by Michael van Buskirk, and he quotes, "The radius of curvature abruptly changes at the junction of the cornea and sclera." Up until very recently, we've had very little information actually about the nature of the sclera and the limbus and that topography shape. The earliest data we had was actually from Marriott in 1966. This was the only quantitative data until a few years ago. And this was actually taken, he took measurements of eyes using impressions. And from those impressions, he painstakingly measured the curvature of the eye. Now, in actual fact, he only measured the scleral curvature. He didn't take into account the actual transition between the cornea and the sclera. A very good piece of work in its day, but painstakingly done, but certainly with some limitations. On a subjective level, Meyer, a Swiss ECP, a Swiss eye care practitioner, actually did some work, and he made some subjective classifications of the corneoscleral profile and that transition. And he looked at the superior transition zone only from the cornea out into the sclera. He came up with 5 different corneoscleral transition models and found the prevalence of them. So he found a fluid complex shape and then a fluid tangential shape. And that fluid tangential shape, which came straight from the cornea, straight into the sclera, 56% of cases. Marked tangential and marked convex, and then finally a concave. Now, why is this important? Perhaps we've been led to believe that soft contact lens fitting in this country has perhaps become a bit of a dead art. Well, I would really challenge that notion. Some people say that soft contact lens fitting has become a process of actual lens selection, taking one fit lens off the shelf. But in reality, it's much more complicated than that. And whilst many soft contact lenses will fit something like 70 to 80% of our population, there's certainly 20% of patients where it will not fit. And why is that? Well, Kakawa in 1979 proposed a model where the soft contact lens can be thought of as a series of concentric rubber elastic bands. And depending on how that peripheral profile of the eye changes, the lens will either be stretched or it will actually be loose and will flap, if you like. So the notion that a contact lens, soft contact lens, just sits on eye and drapes, yes, it does, but it is profoundly affected by the peripheral ocular topography. Now, the limitation with this work was that it was done subjectively. It was only done in the superior meridian. It didn't take into account the other transitions around the globe. But more importantly, it was found to be both inaccurate and non-reproducible. So perhaps we need something that's a little bit more accurate and certainly reproducible to give us accurate measurements. But one of the really interesting things about the work was that what Meyer did show was that the ocular sagittal height of the eye changed as the profiles changed. So that was the really interesting piece that came out of that work. More recently, as I said, we've had ASOCT that gives us a much better impression, and some work that was done at Pacific State with Afe van der Warp and Pat, and I think Atina Graf, wasn't it, showed that there is increasing asymmetry in the scleral shape as you get out beyond the limbus. So looking for a more objective assessment of CSP, myself and my colleagues at Vision Care Research and James Wolfson at Aston University undertook a large-scale study looking at 204 patients, 408 eyes, really trying to get a better grasp of what's going on actually out at the periphery. we measured corneal diameter, but more importantly, we measured the transition zone. You can see it's just LZ and marked as CSJ, the corneal scleral junction angle, to get a better definition of actually how that portion of the eye is actually shaped. If anybody would like a copy of any of these papers, just do get in touch with Arno and we can forward them to you. And you can see there that, again, the assumption is that it's an abrupt transition out from the cornea into the sclera. Now, the really interesting finding about this that came from this study was that the superior and the inferior junctions at the corneal scleral junction transition were actually almost flat in most cases. In the superior aspect, we were looking at a mean reading of 179 degrees, so almost flat, so almost tangential progression from the cornea into the sclera. Inferiorly, much the same story. However, when we look nasally, it's a much, much steeper transition. And when we look temporally, almost flat again. Now, this kind of sits very well with the work that Marcus Ritzman found, and you start to see the picture kind of tying in. And Pat said that sometimes you find some corneas are astigmatic, and perhaps there's a match out in the sclera. Sometimes you get a more spherical cornea, but you get an extreme amount of toricity. But what you start to see is this change of shape over the cornea, and you start to realize that the whole eye is a tremendously complex shape. And I guess my take-home point is that we need to be thinking about the eye more in terms of 3D. We tend to think quite flat, we tend to think about keratometry in the center, and we're not really always grasping the full nature and the complexities of the shapes. And I think we've seen from some of the case studies this morning and from some of the other talk from Pat, you can just start to grasp really just how complicated it is. And then you start to realize why it is that some patients, really, really are a challenge to fit. Now, in the work, we decided to try and classify the type of corneal scleral junction transitions that there were. And we made 3 transition classifications. We took those that were a concave profile. So that's that traditional kind of concept of there being abrupt transition. We took those as being flat or tangential, and we also took those as being convex. Now, that's an interesting concept. When we always think about the transition being concave, in actual practice, there are some cases where it's actually convex. Now, looking at those 408 eyes, it looks rather complicated, that graph, but if you just break it into superior, inferior, nasal, and temporal, and then look at the total, what was really interesting was that in 22% of cases, so almost a quarter of all of the angles around the eye, that almost a quarter were within 1 degrees of 180. Furthermore, almost 78% were within 5 degrees of 180 degrees, and a staggering 98% were within 10 degrees. So this notion that the limbus is an abrupt transition zone is actually, in fact, quite incorrect. And why is this? It's most likely to be associated with the actual physiology of the eye, and there's some thought that it's to do with the placement of the insertions of the recti muscles around the eye. And if we look at the spiral of Tillow there, you can see that the medial rectus is inserted closest to the limbus, and as we go out, you'll actually find that the insertions are further and further away from the limbus itself. And this all starts to kind of tie in very interestingly with what some of kind of Pat's findings and certainly some of the other findings in other studies. If you also look at the distribution of these angles, you tend to find in the red dot to the right, the superior has the greatest distribution. So the greatest distribution of angles is actually flat, and that's in the superior meridian. So, Ken, forgive me, I'm going to be very simplistic here, but I want to make some general points that scleral lens fitting really can be thought of as a process of manipulating the 3 zones in a scleral contact lens to give the required lens sagittal depth relative to the ocular profile. So it's a matching and marrying process. That's a very simple statement, but the art of scleral contact lens fitting is truly that. And we need more knowledge about the shape of the eye to give us the flexibility and the understanding of how to best fit our patients and achieve that. But outside of specialist practice, even with soft contact lens fitting too can be thought of as a process of matching the lens sagittal depth to that of the ocular sagittal height. So, coming back to scleral lenses just for a second, it's a process of matching the ocular sagittal height and trying to allow for the apical clearance once the lens is settled. Now, we can determine the ocular sag by calculation. Graham Young, some years ago, back in 1992, actually did a study where he varied the different parameters and showed the variation and which factors actually affect the ocular sag. And he actually showed that corneal diameter was the greatest determinant, the greatest factor that changed the sagittal height within the eye. Now, just going back to a very simplistic model, if you take a spherical shape, and take a chord of 6 millimeters, you will get a sag of roughly 600 microns. Now, if you just extend that by 2 millimeters to 8 millimeters, you've got almost a doubling of sagittal height. And if we just extend that out, you can see what a profound effect it makes by increasing the corneal diameter, or the diameter in this instance. Now, that applies both to the cornea, but it also applies to your contact lens as well. So as you increase your diameter, you're also increasing either the ocular sagittal height if it's the eye, or the lens sagittal depth if it's the lens. So, looking at that same study of 408 eyes, we took a look at the different diameters. Now, a lot of diameters, a lot of measures, and a lot of contact lens texts, and certainly most manufacturers actually specify prescribing your contact lens in terms of HVID. But in actual fact, if you look at some of those measures with ASOCT, as we've already seen, the solstice actually is actually outside where the curve, where the transition is actually outside the area of the HVID. So in reality, we actually get a greater corneal diameter than that which is specified by HVID. And in this particular study, we found a mean corneal diameter of 13.44, which is, 42 I should say, and a range of between 12 and roughly 14.4. So a very substantially greater width than that which is in the traditional textbooks. But the significance of this is also that you're going to get, therefore, greater sagittal height. So if we look at the kind of variation that we see in the population, this was a deep cornea of 3.8, whereas you can obviously see very shallow corneas of 2.6. Now, when we come back to our traditional keratometry model, this were two patients from this particular study, both a radius of curvature 7.85 millimeters. But what's really interesting is when you look at the cornea on the left with a corneal diameter of 12.8 millimeters versus the cornea on the right, which is 13.65, you see a really substantially, significantly difference in ocular sagittal height of approximately 500 microns. So, as we say, keratometry alone is not enough to give us sufficient information with which to fit our patients. And this is also exacerbated when we have larger, flatter eyes, or with eyes of varying eccentricity. So, the ability to be armed with sagittal height information gives us an awful lot of extra data, and that's one of the areas where the ESP really does excel. I just wanted to just move away for a second. As I say, one of the interesting things that's starting to happen now is we're starting to see a move away from specifying contact lenses in terms of radius of curvature. We're starting to see scleral contact lenses like Pat's ICD lens being specified in SAGs, but also we're starting to see the publication, and this piece of work by A. van der Werf and Chris Mertz, just a few months ago, actually took measures of soft contact lenses in terms of sagittal height. Now, many manufacturers are not currently offering that information, but I can tell you, certainly from this study, and actually behind the scenes, there's now a lot of work, certainly Ave, myself, and a few others are looking at trying to measure all of the lenses on the market and be able to provide practitioners with information as to all of the sagittal heights there. So we can start thinking about that sagittal height story and about fitting our patients once we understand that sagittal height data. And I just wanted to show you really the vast differences. And what I thought was very interesting from their work was that if you look at the Oasis 8.8 lens on the left, which is a 40mm diameter lens, that had the lowest sag. And you would expect that it's a flatter lens with a relatively normal corneal diameter, lens diameter. Now, what's more interesting is if you look at the Pure Vision 1 toric, which is an 8.7, versus the Biofinity toric 14.5, although they are actually labeled as the same base curve, you see there's substantial difference in lens sagittal depth. So I guess the point I'm trying to make here is that you can't necessarily trust the label. So myth or fact time, our lens parameter is always the same as labeled on the packaging. I'm just going to show you a very interesting video. This is actually a lens in a dry state after it's been lathe cut. And it's actually going through the hydration process. It's doing a kind of funky dance. Now, for that reason, when you understand that manufacturers, for certain, actually make lenses in dry state and it goes to this hydration process, they are not necessarily able to accurately measure and determine what the parameters are within the lens once it's finally hydrated. There are moves and there's some new instrumentation coming on the market that will allow that, but for now, our sense of what's on the label and actually what the manufacturers can measure and repeat is not necessarily what you're getting on the label. And that also changes with particularly with soft lenses, with the lens on the eye. And there's actually a significant variation in diameter with the lens with temperature. Most lenses, when they're measured by manufacturers, are actually measured to the ISO standard of 20 degrees C. When you actually put the lens on eye, it actually goes up to 34 degrees C, and then you actually see quite a significant difference of the measured lens diameter versus the actual stated on the packet. But what's also very interesting is actually what's stated on the packet often isn't the case. And if you look at this particular slide, particularly if you look at the bottom lens, the Daysoft 72, the label is actually coming in at something about 14.2, but on eye drops to almost 13.6. And you can see there's a very wide variation between what's actually measured on labels, the blue bars in the room at room temperature, and then on eye are quite significantly different. So this whole understanding of sagittal height and diameter is really quite critical to how we think about lens fitting. Thank you very much.